Good evening, everyone. Welcome to iFocus Online, lecture 256. And now we have successfully moved on to the trauma session from the Squint series. And this will be the ophthalmic trauma session 1. And today we have with us Dr. Purendra Bhasin, sir, from Gwalior, and he will be talking on current classification of ophthalmic trauma and clinical evaluation. I thank the chair for the evening, Dr. Ashok Grover, sir, who will be here with us. And we have an expert panel of Dr. Purendra Bhasin, sir, Dr. Mehul Shah, sir, Dr. Shreya Shah, ma'am, and Dr. Sangeet Mittal. So we all are here and we would love to hear from all of you and your pearls on trauma. So may I please request Dr. Ashok Grover, sir, to introduce Dr. Bhasin.
Good evening, everyone. It's a great privilege to be a part of this iFocus online program and to talk to all of you and to have this dedicated session of ophthalmic trauma classification. And we look forward to a great lecture from Purendra Bhasin, who's an expert in the field and who has had extensive experience with ophthalmic trauma. He's also an expert in cataract surgery and especially in complex surgeries. And he is the director chairman of the Ratanjyoti Netralaya at Gwalior. He's also the senior vice president of the Ocular Trauma Society of India. So we look forward to a great discussion and a great program from him. And let's have Dr. Purendra Bhasin for the talk.
Great, sir.
Thank you, sir, for the nice, kind words from your side. I am really obliged and humbled by your words of wisdom. So without much ado, let me start. Can you see my slide, please?
Yes, sir.
Okay, so my topic today is current classification of ophthalmic trauma, clinical evaluation and investigations. I'm really obliged and thankful to iFocus and Dr. Santosh Munawar for giving me this opportunity to speak on ophthalmic trauma, and above all, giving the importance and weightage to ophthalmic trauma for teaching and learning amongst the PGs and DNB candidates. So I'm Purendra Bhasin. I have no financial interest. So ophthalmic trauma is a major cause of preventable monocular blindness and visual impairment in the world, especially in the developing countries. It is an ocular emergency, and the male to female ratio is 5:1, and predominantly it is seen in the pediatric age group. As per the WHO program for the prevention of blindness, it suggests that annually 55 million eye injuries restrict activities for more than a day, and 750,000 cases will require hospitalization, and 2 lakh open globe injuries are there, and approximately 1.6 million blind from injuries are there, and 2.3 million people with bilateral low vision are there every year, and 19 million with a unilateral blindness or low vision. So this is the magnitude of the situation of ophthalmic trauma. So apart from various other diseases like cataract or glaucoma or retina problem or diabetic retinopathy, ophthalmic trauma is also a major cause for the preventable blindness. It is classified into mechanical and non-mechanical injuries. Mechanical could be open globe injury, closed globe injury, orbital trauma, lid and canalicular or adnexal trauma. Non-mechanical injuries could be chemical, radiation, thermal, electric, or ultrasonic injuries. So my focus mainly will be on the mechanical injuries, but I will be touching to some chemical injuries also during the course of this lecture. So coming to the classification of ophthalmic trauma, Birmingham eye trauma terminology system is the most widely accepted classification introduced in 1996 by Dr. Kuhn and et al. The globe injury could be a closed globe injury or an open globe injury. The closed globe injury could further be divided into contusion or lamellar laceration, open globe into rupture or laceration, and a globe rupture and a laceration could further be divided into a penetrating injury, intraocular foreign body, or a perforating injury. Various terms and definitions are used in the BETS classification system. The eyeball mainly is referred to sclera and cornea, although we all know that posteriorly it involves retina and choroid as well. A closed globe injury is a no full thickness wound of an eyeball. The cornea and sclera are not breached. An open globe injury is a full thickness wound of the eyeball. A closed globe is further subdivided into contusion or lamellar laceration. Contusion means that there is no wound of the eyeball. The damage may be due to the shock wave of the object or to changes in the shape of the globe due to the force of or the impact of the injury. A lamellar laceration is a partial thickness wound of the eyeball, just into and not through and through of the wall. Coming to the open globe subgroups, rupture is a full thickness wound of the eyeball, as you can see on the right side, which is caused by large blunt object. The impact results in IOP elevation and eyeball yields at weakest point and tissue prolapse, like at the limbus. Actual wound is by inside out mechanism and not at the site of impact. And a laceration is a full thickness wound of the eyeball caused by sharp object, and wound is at the impact site and it is by the outside in mechanism, and there can be a tissue prolapse also, like a uveal prolapse or prolapse of the lens or prolapse of the vitreous. Now, laceration could be subdivided into a penetrating injury, which is an entrance wound is present, as you can see on the right side, right up picture. Intraocular foreign body is a penetrating injury. One or more intraocular foreign bodies may be present. Technically, it is a penetrating injury, but as the management and prognosis differs, that's why it is classified here separately. Perforating injury is when there is both entry and exit wounds are present in a globe, and both are caused by the same object, as you can see on the bottom right picture. And this is at the same level, anterior segment we can see, but this entry and exit wound could be anterior to in the cornea and posteriorly maybe at the posterior sclera as well. Blunt trauma can further be divided in a coup or direct contusion. It is a focal injury resulting from direct blunt object trauma. It may lead to bruising and rupture of microvessels or other types of tissue destruction. Example like corneal abrasions. Counter-coup injury is caused by the distant damage away from the actual place of impact due to compression wave force transmitted through fluid contents in all directions. Like angle of the anterior chamber, it pushes iris lens diaphragm posteriorly and strikes the retina and choroid, and it causes a commissurectomy. So it is a distant but a damage from the shock wave or compression wave, as you can see in below B diagram. And concussion is a diffuse type of injury due to rapid acceleration, deceleration, or oscillation of cornea and surrounding tissue. Hydrostatic shock waves are generated from the direct impact of a blunt object or from reflected and rebound compression. As you can see in bottom C and D diagram, the force is directed towards the center and it is reflected as well as it is rebound. and it causes more of edema. Coming to the classification further into open globe and closed globe injury, type we have discussed just now. And for the prognostic value, it is divided, we have to go further. And we can divide into various grades from grade 1 to grade 5. Grade 1 is a better vision, and grade 5 is a worst vision, that is a no light perception in both the groups. And pupil, we have to look at a positive RAPD or a negative or no RAPD, and that has to be written as positive and negative. And zone in open globe injury is zone 1, 2, or 3. 1 is when it is related to the cornea up to the limbus, corneoscleral limbus. And zone 2 is from limbus to a 0.5 millimeter posterior into the sclera. And from beyond 5 millimeter of the sclera, it is called as zone 3 or a posterior bone. In a closed globe injury, the type could be contusion, lamellar laceration, superficial foreign body, or a mixed type. Grades can be from grade 1 to 5 according to the visual acuity of the patient. Pupil is positive or negative RAPD. And zones in closed globe injury is external, which is limited to the conjunctiva, sclera, or cornea. And zone 2 is anterior segment, which is the cornea, including posterior capsule and pars placata. And zone 3 is posterior segment, all structures posterior to the posterior capsule. You can see in this diagram, zone 1 in the open globe subtype, zone of injury is zone 1, which is up to the corneoscleral limbus. Zone 2 is 5 millimeter from the limbus into the sclera, and zone 3 is beyond 5 millimeter of the sclera. And similarly in a closed globe injury. Coming to the ocular trauma score calculation, we have to first look at it, see the raw points. And raw points are given to various things. Like when there is a no light perception, the raw point will be less, that is 60. When there is a light perception of hand movement of vision, raw points will be 70. If it is 1 by 200 to 19 by 200, raw points will be 80. From 2200 to 2050, it is 90, and beyond it is 100. So better quality of vision, we give a out 6-9 vision or better, then we give them 100 raw points to begin with. Then if there is a rupture, then we have to decrease minus 23. If there is endophthalmitis, we have to decrease minus 17. Perforating injury minus 14, retinal detachment minus 11, and relative afferent pupillary defect we have to decrease minus 10. So some of the raw points, if it is 0 to 44, the ocular trauma score will be 1. In this, the chances of this is the prognostication of the by this ocular trauma score, we get to give the prognosis to the patient we can give. So if the ocular trauma score is 1, so the chances of no PL in this patient will be 74%, and chances to achieve 20 by 50 vision is 1%. And if the raw points summation is 45 to 65, we will take it as a ocular trauma score is 2, and that's in this the chances of no PL is 27%, and to get the best vision will be 15%. So this will be further divided into up to 1, 2, 3, 4, 5. In ocular trauma score 5, the chances of PL-PR are no PL is 0%, and when we have a better score, and the chances of achieving best vision is 94%. So let us take an example. A patient reports with a penetrating trauma with initial visual acuity measured as hand movement with a RD and relative afferent pupillary defect. So as per the OTS score, raw score, we take it as a hand movement. Initial vision score is 70, and as there is a rupture of the eyeball, So we will decrease minus 23, there is retinal detachment, minus 11. Further decrease because of the afferent pupillary defect, minus 10. So 70 minus 23 minus 11 minus 10 is 26. And ocular stroma score is very bad here, and which is in the bracket of 0 to 44. It comes in the category of 1. So chances that the said patient has 74% high chance of no PL and very less chance that a patient will get a vision of 6/9 or better. Another example of ocular trauma score calculation, vision is 2200 with no signs of RD, endophthalmitis or afferent pupillary defect. The raw score is 90, basic initial vision score is 90. Because of the RD rupture, there is a minus 23. To 90 minus 23 will be 67, which comes in a bracket of 66 to 80 or ocular trauma score category 3. So in this, the chances, patient has 2% chance of no PL and 41% chance of vision above 6/9. So, so this way we can calculate it further. Coming to the pediatric ocular trauma scoring, which is different from adult ocular trauma scoring because of the age. And at early age, the chances of damage or recovery of vision is bad. Rest of the conditions may be the same. So in this, no light perception raw points will be 10, and with the better 6/6 or 6/9 vision, the raw points we will take it as 50. And here we have added the age also. If the age group is from 0 to 5, we will add raw points will be 10, and between 6 to 10 it is 15, and 11 to 15 it is 25. And as per the zone of the involvement, like in zone 1, the raw points will be 25, zone 2 it will be 15, zone 3 it will be 10. Concomitant eye pathologies like iris prolapse, we have to decrease 5. So sum of A, B, C minus the concomitant eye pathologies like iris prolapse -5, hyphema -5, unclean injury -5, delay of surgery more than 48 hours -5, presence of traumatic cataract -10, vitreous hemorrhage -20, retinal detachment -20, and endophthalmitis -30. So if a child is of 14 years age, as per initial vision, as per the score is as per the vision of the patient count finger, score is 30, raw score is 30. Age is 14 years, so we'll add 15 to it. Zone is 1, so we will add 25 to it. Concomitant pathologies, iris prolapse is there, we will decrease 5 from it. So total raw score is 65, and we will the OTS category is same as we have seen in the for the adult, which is 45 to 65 years, which falls into category 2. So this means that there is a 27% chance of less chance of PL, that patient will have no PL, and 15% chance of the vision above 6/9. So pediatric ocular trauma scoring can be done in a pre-verbal children or in a children who are not cooperative for the visual acuity assessment. So in the raw score, we should multiply it by 2, where we have taken age plus the zone of the patient, we multiply it by 2, and then with the corresponding pathologies can be decreased. So in such a way, we can calculate in a pediatric ocular trauma score in a pediatric age group patient who are not conversant with the visual acuity or not cooperative. UK pediatric ocular trauma study has included other segment also, like eyelid trauma and various other aspects like intraocular pressure and orbital trauma and extraocular trauma into it for the consideration of the scoring, and this is said to be the better one. Potential additional variables currently not included in the ocular trauma scoring, which should be there, are the presence or absence of adnexal injury, orbital fracture, zone 3 injury, involvement of the visual axis, presence of the wound in the visual axis, intraocular foreign bodies, vitreous hemorrhage, and the time for the presentation and time for the management and the involvement of the lens and the corneal status. We have, and Dr. B. Shukla and myself and Dr. Mehul Shukla has come out with various other classification, improvised classification and a simplified classification of ocular trauma, which can also be considered. But I think that is all beyond the scope of this lecture. Coming to the evaluation of case of trauma, like in any other case, we should do history taking, a systemic examination. The general condition of the patient has to be evaluated. Visual acuity testing, ophthalmic examination using slit lamp and ophthalmoscope when it is feasible should be done in all these cases, and we will cover the medical legal aspects also. This is the scope of the talk further in now. So in history, we should note down whether there is a sudden or gradual changes in the vision since the trauma has occurred, presence of pain, diplopia, and photophobia, date and time of incident should be recorded, mechanism of injury, whether it is accidental, intentional, or self-inflicted, where it has occurred, whether at a home, workplace, or while doing a recreational or sports activity, whether the patient was wearing any glasses or protective eyewear, mechanical trauma with a foreign object, and if there is a foreign object, then the size and shape of the object, distance from which it has come, exact location of impact, because all these things are very important. A tennis ball will give a different kind of injury as compared to a golf ball or a cricket ball. So in size and shape and penetrating or a sharp object will induce a different kind of injury. And we should note down a past ocular history, whether there is any pre-existing ocular diseases, previous ocular surgery, visual acuity prior to incidence. We should look for any intraocular or periocular appliances like IUL has been done in the past, or there is a history of retinal scleral buckle for the retinal detachment, or an glaucoma drainage implant has been placed in the eye. We should look for a tetanus immunization. Any treatment taken for the injury in the past at the PHC level should be written in detail. In the cases of foreign bodies, composition of foreign body, whether it is contaminated, has to be noted. A vegetative foreign body will definitely induce a fungal infection, that should be remembered. And a metallic foreign body will not induce infection more because of the heat generated while transmission. And sometimes it can induce contamination and intraocular infection also. Origin and exact mechanism of impact should be noted. Whether there are single or a multiple, like in blast injuries, there can be multiple foreign bodies. Injuries from animals, what type of animal and nature of injury, whether it is by a bear bite or a cow horn injury or the cow tail or buffalo tail injury, all this should be remembered and noted. And we should try to locate the animal to test for any transmissible disease like a dog bite. Systemic examination should be done for the general condition of the patient. Any associated head injury or fractures, whether the patient is conscious, level of consciousness, everything should be mentioned. Any systemic condition that may need urgent intervention should be taken first. So coming to the initial examination of an ocular and adnexial injuries for all the PGs when they are seeing the patient for the first time. If you suspect an open globe injury, you may perform a quick examination before taking the full history. Inspect eyes without placing pressure on the globe, and one should use Desmar's retractors. Palpate for discontinuity of the orbital rim and detachment of the medial cathode tendon, and which are the signs of severe orbital trauma. A positive sedal test will help detect leaking aqueous or exposed vitreous. The presence of an intraocular foreign body suggests globe penetration. A plain film X-ray, if it is available, or the CT scan, which is preferable, should be advised. If a globe is obviously open, do not check pressure or the motility, or do not dilate the traumatized eye. Place a shield over and avoid bandage or patching of the eye. Avoid ointment on an open globe. A non-preserved antibiotic exams, for example, moxifloxacin, are okay if there is a delay in getting to the operation room. Complete ophthalmic examination is done. We should note visual acuity if it is possible, color vision if it is possible, slit lamp examination, photography of the eye should be done for the record. Ophthalmoscopic examination by direct and indirect ophthalmoscope if it is possible and the patient allows it to do. Proper documentation and medical legal case registration is very, very important. Visual field by confrontation test if it is possible. Intraocular pressure recording if it is possible. Head posture, facial symmetry, eye alignment. We should look for orbital fracture, any crepitus, infraorbital hyposthesia, or restricted extraocular muscle movement. In cases of orbital or the paranasal sinus fractures, which will lead to all these things, crepitus, infraorbital hyposthesia should be seen. Extraocular movements like cranial nerve involvement or paralysis is seen in cranial nerve involvement or entrapment of muscle. We should look for the continuity of eyebrows, eyelids, and eyelashes, and should look for any abrasions, marginal and canthal tears, including canalicular tears, ecchymosis of the lids and edema, ptosis if it is present, whether it is a mechanical ptosis or the paralytic ptosis. In ophthalmos, exophthalmos, everything should be noted. Look for the conjunctiva for chemosis, subconjunctival hemorrhage. Examine fornices for any foreign body by double eversion. Conjunctival foreign body or abrasions, lacerations, emphysema should be noted. In cornea, we should look for any abrasion, do the fluorescein staining. So corneal foreign body, metallic or vegetative matter should be noted. Ulceration, if it is there, corneal or corneoscleral tear with or without uveal prolapse, extent and the shape of the tear, if it is, if you are able to record, should be recorded, and we should do Siedel's test. Look for in the anterior chamber, look for the depth, do the conioscopy to see the iododialysis, foreign body in the angle or any angle recession, and see for the cells, flare or any iritis, traumatic iritis, hyphema, blood clots, hypopion, cortical matter or any foreign body in the anterior chamber or presence of the vitreous in the anterior chamber. And iris should be examined before dilating the pupil. Look for iridodialysis, iridodonosis, iris prolapse, sphincter tear, traumatic iritis. Look for the pupil size, shape, and reaction. Traumatic mydriasis is very common. RAPD and a D-shaped pupil in iridodialysis is seen. Lens should be looked at, whether it is clear or cataractous. There is any presence of subluxation or dislocation of the lens in the posterior chamber or in the anterior chamber, or it has come out from the wound. Look for the stability of the lens, clarity of the lens, presence of osseous ring on the anterior surface of the anterior capsule of the lens, and the rupture of the anterior capsule. Coming to the vitreous, we should look for any pigments in the tobacco dusting in the vitreous, anterior vitreous by the slit lamp examination. Look for any hemorrhage, intraocular foreign body, because there can be chances of posterior tear, peripheral tear of the retina. Weiss ring indicates PVD, choroidal rupture and detachment should be seen. Edema of the optic nerve or hemorrhage at the optic nerve should be noted, and cup disc ratio should be noted. Avulsion or partial, or whether it is partial or complete of the optic nerve, if it is visible, should be seen and should be recorded. Optic neuritis, if it is there, we should look for any edema of the optic nerve, and margins are blurred. And in retina, commercial retinae, intraocular foreign body, retinal tears, holes, dialysis, and detachment should be noted. Routine hematological investigations are advised, and in radiological imaging, plain radiography should be done in almost all of the cases if it is available. and X-ray, AP, and lateral view, and PNS for the involvement of paranasal sinuses. And we should look for orbital fractures or any presence of any intraocular foreign metallic foreign body or intraorbital metallic foreign body will be seen through this. My best is to do a CT scan or computed tomography. This is indicated if there is any bony involvement is suspected. We should go for a plain or contrast. We should advise. And in axial sections are suggested when in the trauma to the globe or medial rectus and lateral rectus muscle. And when there is involvement of medial and lateral walls of the orbit, then we should ask for axial sections. And coronal sections are suggested when we have involvement of superior rectus or inferior rectus or roof and floor of the orbit. And it is indicated in all open globe injuries. And for the posterior segment visualization, and when there is a suspected intraocular or intraorbital foreign body and there is a hemorrhage. And in cases of all orbital fractures, we should suggest or get a CT scan done. MRI is restricted or indicated only when there is a soft tissue lesion, and to visualize periocular soft tissues, involvement of the vascular involvement is there, or intracranial pathology or optic nerve lesion is suspected. It is absolutely contraindicated in metallic foreign body or the patient is having a pacemaker or any metallic implants. Ultrasonography is suggested, and we should do it with extreme caution in condition of open globe injuries, and it is preferably avoided in such open globe injuries. It is indicated to look out for a vitreous hemorrhage, PVD, and retinal tears and detachment if it is there, choroidal rupture, suprachoroidal hemorrhage, scleral rupture, to visualize lacrimal gland, extraocular muscle, soft tissues, foreign bodies, or the optic nerve avulsion or optic nerve rupture is there. Coming to the last aspect, that is a medico-legal aspect, which I wanted to touch here, because we are most of these cases are medico-legal. The decision of labeling a case as medico-legal lies with the doctor attending the case, depending on the cause of the trauma and nature of injury. A doctor should do everything possible to resuscitate the patient and ensure his well-being. All legal formalities are to be suspended till the patient is resuscitated. Very important is that every doctor is bound to provide medical aid to the victims irrespective of the cause of injury. We cannot take any excuse of allowing law to take its course. Supreme Court judgments in case of Permanent Katara versus Union of India says that all these cases, medical aid should be, primary medical aid should be provided to maintain the airway and the respiration or the breathing. Reporting should be done on proper pro forma, giving all necessary details. Avoid abbreviations, overwritings. Corrections, if any made, should be initialed and signature should be placed and with the date. Medical legal records should be stored under safe custody for 10 years. Details to be noted with the age, sex, and the identity of the patient with the complete address, if it is possible. Date and time of reporting, time of incident, who has brought the patient, and the identification mark or the fingerprint of the patient should be taken. Coming to the consent before we take the patient of an MLC patient for the surgery, it should be taken for a particular purpose or what surgery we are planning or procedure. It should be mentioned in writing by the doctor or by the attendant and nursing staff. Consent should clearly explain the procedure to be performed and its associated risks. If patient is minor or less than 18 years of age, consent of guardian to be obtained, or if the patient is unconscious, then we can take the consent from the attendants. Admission or discharge of MLC case is to be notified to the nearest police station. A medical legal register should be there in a casualty or the emergency room to report all MLC cases, and entries should be made accordingly. A failure to report a medical legal case renders doctor liable for negligence and deficiency of service. A good working knowledge of law regarding MLC cases helps one build confidence in dealing with such situation. Coming to the second part, that is a non-mechanical or most common of it is a chemical injury. Chemical burns constitute 7.7 to 18% of all the ocular trauma. Chemical burns are caused by acids and alkalis. Alkali burns being the most common, and they are worst. They are much problematic. Alkali burns, in the alkali burns, the alkalis dissociate into an hydroxyl ion and a cation on the ocular surface. The hydroxyl ion causes saponification of the cell membrane, fatty acids, while the cations interacts with the stromal collagen and glycosaminoglycans. This interaction facilitates further penetration in the corneal stroma. So the alkali burn, the progress of the burn continues for many hours and days. Acid burns, the acid dissociates into the hydrogen ion and the anions in the cornea. The hydrogen molecule damages the ocular structure, ocular surface by altering the pH, while the anion causes protein denaturation, precipitation, and coagulation. This prevents deeper penetration of the acid. The pathophysiology is initially what happens is on day 0, the clinical findings relate to the severity of the injury. It is graded according to the degree of limbal, corneal, and conjunctival involvement. In day 0 to 7, the acute phase of the injury is there. In this, the epithelial regrowth begins to occur if there is sufficient amount of undamaged limbal stem cell present. And we should direct our treatment in encouraging the growth while reducing the inflammation. From day 7 to 21, which is the early repair occurs in the eye, the corneal and conjunctival epithelium and keratocytes proliferate. So the more of inflammation is there. So in mild injuries, complete reepithelialization occurs. In severe injuries, persistent epithelial defect will form, and activity of collagenase peak between 2 to 3 weeks, while collagen synthesis continues. Treatment should be aimed to attempt to maximize collagen synthesis while minimizing the collagenase activities for further damage to the wound. Late repair occurs in the wound after 21 days, and a mild injuries repair is completed. In grade 2 injuries, while focal stem cell loss is there, focal conjunctivalization of cornea occurs. In a more severe injury, grade 3 to grade 4, delayed reepithelialization of cornea, repopulation by conjunctival epithelium, stromal ulceration, permanent scarring may develop. In severe limbal stem cell damage, despite optimal management, this eye cannot be salvaged. There are various classifications, and I will restrict myself to Roper Hall classification and Duas classification, which are more relevant and more popular. Roper Hall classification is divided into grade 1 to grade 4. The prognosis in grade 1 and grade 2 is good. It is at the graded by the involvement of limbal ischemia. In grade 1, there is no limbal ischemia and there is a epithelial damage. In grade 2, if it is the ischemia is less than 1/3 of the limbus, and there is a haze, but iris details are visible. In grade 3, the prognosis is guarded, and ischemia involves 1/3 to half of the corneoscleral limbus, and in the cornea, the total epithelial loss with haze is there, which obscures the iris details. In grade 4, prognosis is very poor. More than half of the limbal stem cells have been damaged, and cornea has become opaque with no iris and pupil details visible. In the Duas classification, it is better, and now most of us, we follow this only. When there is no limbal cell involvement, we say that is the conjunctival involvement is there, no conjunctival involvement is there. the prognosis is very good, and we grade it as 1. In grade 2 and grade 3, the less than 3 clock hours and more than 3 to 6 clock hours is there, and 30% of the conjunctival involvement is there. In grade 3, 30 to 50% of the conjunctival involvement is there, and in millimeters also we can measure between 3 to 6 millimeter and of the limbus is involved. In grade 4, the good prognosis is from good to guarded when more than 6 to 9 clock hours of the limbus is involved, and conjunctival involvement is more than 50 to 75%. And grade 5 is poor, guarded to poor, and grade 6 is very poor when almost all of the limbus is involved and total conjunctiva 100% is involved, and prognosis is very, very poor. Thermal burns are caused by the accidents which are associated with fireworks explosion, or boiler or steam or boiling water or molten metal is exploded. Thermal burns generally involves the lid, face, and sclera, conjunctiva, and the cornea. It causes tissue coagulation by the effect of the heat, and toxic heated metal splash or fireworks injury with the chemicals present in the fireworks like magnesium sulfate, etc. They cause additional damage by the metal toxicity and cause further tissue necrosis. To conclude, ocular trauma is a major cause of preventable monocular blindness and visual impairment in the world, especially in developing countries. With the implementation of suitable preventive strategies, early presentation of the trauma cases, giving proper first aid measures at the PHC level, primary level, and referring to secondary or tertiary care centers, specific cases for further management, we can salvage the vision of the patient and the eyes. I thank you for your patient hearing.
Thank you so much, sir. Bhasin, sir. I would request our panelists to just say a few words before we move on to the questions. Grover sir, Mehul Shah sir, ma'am, any words, comments from you? Then we'll move on to the questions from our social media portal.
Thank you, Dr. Purendra. I think you very comprehensively covered all the aspects. First of all, you stressed the importance of the classification, which is so important in an individual given case, and then the ocular trauma score in prognosticating. And then you went on to enumerate the various conditions in which the involvement occurs with blunt trauma, with sharp trauma, and with chemicals. And you went on to tell us how to examine, how to take the relevant history, which will be valuable in the management. And of course, then you talked about the medical legal aspects, which are so important in trauma. I think what was most important was that you stressed the evaluation aspect and then prognostication on the basis of ocular trauma score by examples. I think those would be the important carry-home lessons for everyone. Of course, the postgraduates need to learn a lot more about individual cases of the evaluation and the planning for management. And I'm sure the subsequent lectures will take care of that. What you also stressed was the importance of ocular trauma in the amount of morbidity and the loss of vision that is taking place globally, and how that can be taken care of much better if we do a much better coordination between specialties to take care of the systemic aspects, coordination between different subspecialties in ophthalmology to provide the best possible care. And all this can only happen if we coordinate things better, provide a better education and fellowship programs in ocular trauma, and therefore everyone, including the public, gets better educated to prevent ocular trauma, and advocacy therefore becomes very important. So I think all these aspects have been covered rather well. I would open it up for all the panelists to highlight what they think are the most important points and go on to the questions from the audience.
One question has come from the audience regarding use of steroids in chemical injury in the early days of the chemical injury. So, should I take the
Please,
answer?
please,
Should I?
please,
Yes, sir. Please go ahead.
I think I will prefer to use plain antibiotic rather using these steroids in such cases, because we are not sure of whether in the early very first day, whether there is infection present or not. So plain antibiotic is much preferred than using a steroid in such cases. Dr. Mehul, what do you suggest?
Yeah, you rightly said because according to question, the epithelial defect is very large. So initially we may not take the start the systemic steroid, but there is a requirement of autologous serum for whole blood of the patient. That is very useful to
For the
start with the
healing.
treatment with the plain antibiotic rather than corticosteroid.
But if there is no infection, then we can definitely add a mild steroid in a low dose, low frequency. If you are absolutely sure that there is no infection, because this is going to help decrease the collagenase activity, and it will decrease the inflammation and the further damage. But this is restricted to further initial 7 days only of the injury. After that, we should stop using the steroids. From beyond 9 days, we should never give. And all these cases should be seen very frequently. That is very, very important. Then only you can give. If you are suggesting the patient to come after a week or 10 days, or the patient is not able to come, better not to start steroids.
I think Dr. Purendra has very rightly stressed that in the initial period of chemical trauma, when the inflammatory component and the inflammatory activity is at its peak, steroids have a very positive role. So wherever possible, steroids should be used in the early post-operative, early post-injury period to decrease the trauma. Beyond 10 days, yes, of course, it has to be a more titrated approach, because then you would have other considerations come in. But during the first 10 days, yes, most certainly, steroids have a very positive role to play, topical steroids.
Another question has popped up from Dr. Whelm. Role of systemic steroids in cases of uveal tissue injury to prevent sympathetic ophthalmitis.
Dr. Bhasin, go ahead.
Yeah, okay, sir. I think, in my opinion, use of systemic steroids is of utmost important in all these cases to decrease the inflammation of the eye, along with the undercoverage of the broad spectrum antibiotic. That should also be given. And this helps in both initial reduction in the inflammation and in sympathetic ophthalmia to some extent.
I think the most important aspect is putting the wound together.
I think
there is no better prevention than that. Just making sure that you repair the wound well. And sympathetic ophthalmia has now become a very, very rare entity after the repair of microscopic repair of open globe injuries has started.
That is the primary thing, sir. We have to maintain the safety eyeballs.
The question is regarding the uveal tissue. So the interval between the injury and the sympathetic ophthalmia is very much variable. So maybe we can treat the systemic initial part with the systemic steroid, but if that sympathetic ophthalmia occurs after 3 years or 4 years, then we are not aware how to give the prophylactic corticosteroid, which is not possible because that may occur after 3 years, 4 years, or 5 years of injury.
Yeah, true. But then we have to give IV methylprednisolone. Heavy steroids should be given to overcome it.
No, that occurs. He is asking about prophylactic steroid.
No. Then I think systemic steroids in cases of uveal tissue injury to prevent prophylaxis. I think that it has not much of a role in preventing sympathetic ophthalmia. Correct. It doesn't have much role.
Yeah. It is rare
We
enough.
can start with it occurs.
Yeah, true. But early repair is indicated. We should repair the wound, open wound, as early as possible. That is the most important thing. Whenever the condition allows, we should do the repair under general anesthesia.
Correct, sir. So one Dr. Gyanu Raja on Facebook, he has asked, which one do you suggest in suspected intraocular foreign body, X-ray or CT? What are your views?
CT scan.
I think it's more
It is more useful in all aspects. It gives all the information. The collapse of globe or the type of foreign body, intraocular multiple foreign bodies, and detachment. To some extent, detachment also can be seen, and presence of vitreous hemorrhage. So, or damage to the posterior eye wall and the orbital involvement, everything will be seen by the.
Correct, sir.
Dr. Mehul is saying something. You are muted, sir.
So you're muted, sir.
Dr. Mehul, you are muted.
With current, yeah, sir. We are with current 3D modulation, we can identify the positioning as well as complete localization of the foreign body, which helps very much during the management period. So when we go in for the surgery, during vitreous surgery, it's very easy for us to locate the foreign body, and even if it is surrounded by vitreous hemorrhage, it will be easy for us to locate and remove that foreign body.
If CT scan is not available, then a brain skygram, X-ray, AP lateral view is suggested.
I think CT scan is essential part now for at least for trauma.
Intraocular foreign body and globe perforation.
Correct, sir. So another question is, can you comment on the timing that one should choose for performing vitrectomy in a traumatic eye?
Dr. Mittal is there. Dr. Mehul.
Current concept is very clear. After primary repair, initially there used to be a debate whether we should wait for posterior vitreous detachment or not. But current concept is 100 hours should be the optimum time. We should operate the eye within 100 hours of the injury.
As early as possible.
100 hours.
Yeah.
Maybe you can take time for primary repair if you are not clubbing those two, but then you can give 3 days time.
Yeah, because
but earlier it was 7 days to or the 7 to 14 days for the initiation of the PVD. But the PVD can be induced on table, and we don't have to wait.
Recently, very clear view is 100 hours.
100 hours. Sir, want to say something? Dr. Grover, sir.
But a delay only allows the ingrowth of cells and cyclitic membranes and so on. So it increases the complexity of the repair and reduces the result. So I think, as Mehul pointed out, the concept has changed towards earlier repair.
And so what about the repair of traumatic cataract?
So as when you do a primary repair, wherever possible, you should avoid lens surgery. But in case there is free floating lens matter, or there is a secondary rise of intraocular pressure that is taking place, or an inflammation is being induced, or there is extensive leakage of the lens matter, then you have to tackle it at the same stage. The advantage of a second stage surgery, wherever feasible, is that you work in a quieter eye, you can evaluate much better, you can evaluate the posterior segment, you can possibly calculate the intraocular lens power much better, and you get a much quieter eye and a much better response. But where you are forced because of those factors which I mentioned, you would go ahead at the primary trauma itself.
Another question related to the traumatic cataract repair is precautions to be taken during the surgery for such a like traumatic cataract surgery. Like what should we be ready with, or what are the things that can go wrong? Probably the
Yeah, I think in a traumatic cataract, if there is a loose cortex or if there is a rupture of the anterior capsule of the lens, so we should remove all the loose cortex from the anterior chamber, clear the anterior chamber at the time of primary repair. And what I do is I clean all the anterior chamber and remove the lens matter as far as possible and wait for some time, as Dr. Grover has said, and then we should do and maintain the iris as far as possible at its place, because this is very much required. Iris diaphragm is very important to decrease the glare and halo. And we will do secondary sitting the IOL implantation. And if there is a vitreous in the anterior chamber or there is a rent in the posterior capsule, we should be very, very careful in removing the lens matter and do anterior vitrectomy in all these cases. And if the posterior capsule is ruptured, then in such case, I think it's always better to give the intravitreal antibiotic also, because in such cases, the chances of endophthalmitis are very, very high. So we should always give intracameral, intravitreal antibiotic in the posterior segment.
With current available anterior, with available anterior or anterior segment OCT, it is easy to find out pre-existing rupture of the posterior capsule, and which is important to detect. Or because with open globe injury we cannot do the UBM, but we can use the anterior segment OCT to detect the rupture of the posterior capsule prior to the surgery.
According to that, we can plan the surgery. Correct. But when there is a large wound is there with uveal prolapse, collapsed anterior chamber, presence of hyphema and blood clots in the anterior segment and mixed with the cortex, then it is not possible to do OCT, I think. In such a formation of the wound, integrity of the cornea and sclera, and formation of anterior chamber, preserving uveal tissue as far as possible, and removing the lens matter will make the eye quiet in a better way in the early post-operative period.
So even if you are operating late, I mean, if you're not required to do it at the primary surgery, it is important, as was stressed by Purendra, that you think of the possibility of an previous anterior capsular rupture with fibrosis of the capsule. So the capsulorhexis may be difficult. Secondly, the possibility of there being a posterior capsular rupture. And thirdly, always think of the possibility of there being an existing zonular break, even if it is not so evident. And of course, the possibility of vitreous presenting. So you should be able to think of all these possibilities when operating and keep yourself prepared to manage all these eventualities.
And the last question for the day is, how do you manage hyphema? When should we treat it conservatively? Probably the audience wants to ask, and when should we go on for the clearing of the blood?
I think hyphema has to be tackled at the time of primary surgery. So it is important to make
supposing it is a blunt trauma. And there is a hyphema.
Yeah.
When would you like to do a conservative treatment, and when would you do a
wash?
I think 8-ball hyphema has to be removed. If the hyphema is less than 1/3, then we may try to treat that conservatively. Otherwise, we have to wash it off to avoid the possibility of secondary glaucomas.
So I think there has to be a nuanced stance, as Mehul is suggesting, that if there is a small hyphema 1/3 or to maybe up to half, and you observe it, the pressure is not elevated, and you can then wait and see if it clears by conservative measures such as some rest to the eye, rest to the patient, and some medications such as topical steroids and maybe atropinization, which there is some controversy about. And then you observe if it absorbs, fine. If it doesn't, is not showing signs of absorption, and particularly if it is a large hyphema or a black ball hyphema, or if the pressure is high, and pressure is unacceptably high. Now, there are various definitions for that, over 3 days, over 5 days. But what is sufficient is to know that if the pressure is high over 35, let's say for 5 days or more, then certainly you would intervene and take care of the drainage of the hyphema, so that you do not allow one, optic nerve damage, two, corneal blood staining. Both those things need to be prevented.
Even if it is 2/3 of the anterior chamber is involved, and hyphema appears to be fresh red, we should do it if the pressure is high. We should remove it if the pressure is, and the results are very good. There is no risk involved. You should do it in a closed through by the paracentesis wound and in a closed way, and it doesn't create any problem during the evacuation of the hyphema.
In the closed globe contusion, when the blood is full chamber blood is there, then many of the time we are not aware about the position of the lens and lens damage which has occurred because of closed globe contusion. Maybe zonular damage can be there and we are not aware. So we have to take care of all these factors while washing the anterior chamber.
And of course, watching the patient post-operative, even after you've drained or even after a hyphema which has spontaneously cleared, you should be on the long term on the watch out. Maybe repeat an examination after 3 weeks to look for any dialysis, retinal dialysis, and the presence of the angle
secondary glaucoma.
Of course, the Berlin's edema, so on and so forth, choroidal rupture at the back, all those signs which may have been masked earlier because fundus examination was not possible. So at the end of 3 weeks at least, should do a good thorough dilated fundus examination and of course a good gonioscopy.
Is there a risk of rebleeding in such patients once they have cleared out the blood?
Yes. And that
is there.
Something to be cautious about, that rebleeds are a problem, and in rebleeds then you have the role of aminocaproic acid or other oral agents in trying to prevent it. But that is the one reason, because of the rebleeds, that you try and restrict the activity of the individual in the first week or so, because 3 to 5 days or 7 days is often the period when rebleeds are even after the initial hyphema has cleared.
And so if we are planning to treat them conservatively, should we be following them every day, or there can be a gap when we call the patients to check the IOP or just to keep them under?
It depends on the severity of the hyphema. If it is a mild hyphema clearing quickly, then you may call them after a few days. But if the intraocular pressure is unacceptably high, or if the amount of hyphema is 2/3 or more, then I would much rather observe them daily to make sure that the pressure rise is not unacceptable.
All right, sir. So I think with that, we have wrapped up the questions from all the social media portals also. Thank you so much, Purendra sir, Grover sir, for being here, for taking part in our discussions, and Mehul sir and Shreya ma'am, who was there, and I think now she is not here in the portal.
She has gone for some other meeting.
Okay, sir. I think next class is hers, so we'll be seeing her then. Yes. Grover sir, any concluding remarks from you?
Would like to thank iFocus, Santosh, Rolika and Shefali for organizing this so beautifully, and Purendra for a superb lecture which covered all the aspects. Of course, Mehul and Shreya. Wonderful to have this discussion together. Thank you, iFocus. Thank you, Santosh, for this. opportunity to talk on ocular trauma.
Thank you,
Thank you,
Dr.
sir.
Santosh.
Thank you all. Thank you, Dr. Shivali, Dr. Rolika, Mr. Rolika. Thank you, Dr. Mehul, and our chief, Dr. Grover, sir.
Thanks to the
Thank you
audience
all.
to be with us.
Thank you, audience. Thank
So
you,
we,
all the PGs and all the best.
yes.
Anything you can write to us, and they are free. All the PGs are free to inquire anything directly also from us. And maybe through you also you can. Thank you.
And so
Thank you very much.
Thanks a
before
lot.
we leave, I have just two announcements to make. One is the physical eye focus is back. So everybody can register. And it is from February 26th to March 5th in New Delhi. So we are open for 300 delegates. So register as soon as possible. I'm sure you don't want to miss it. And the registration link is given on this slide above. So please do contact and register for the same.
Right, and we already have 70% registration. So you guys need to please really hurry up so that we can all see you there.
Yeah. And the
Thank
next
you
class
so
is
much,
going to
everyone.
be, the next class is going to be on November 23rd, which is Trauma of the Eyelid, Adnexa, and Extraocular Muscles by Dr. Shreya Shah. So, see you all.
Right.
Good
Thank
night,
you,
everyone.
everyone.
Thank you.
And
Bye.
good night.
So much,
Thanks
everyone.
a lot for being